This is the course Remission of Type 2 Diabetes and Reversal of Insulin Resistance with Lifestyle Medicine. This lesson is on insulin resistance in type 1 diabetes, latent autoimmune diabetes in adults, or LADA, and type 2 diabetes. I'm Kylie Buckner, and I will be here to guide you through this lesson. The learning objectives for this lesson are to distinguish the key differences between the two types of autoimmune diabetes, type 1 diabetes and LADA. We're going to illustrate how low carbohydrate diets cause insulin resistance in both type 1 diabetes and LADA, evaluate which tests are vital to understand a patient's autoimmune status and treatment protocol. We will review the sequence of events of whole body insulin resistance in multiple tissues that occurs in both type 1 diabetes and LADA, and also describe how low carbohydrate diets can cause double diabetes. So first, we're going to look at understanding autoimmune diabetes in both type 1 diabetes and LADA, and start with a review of pancreatic physiology. So your pancreas has two functions, both exocrine and endocrine. The overwhelming majority of your pancreas with exocrine function is responsible for the production of digestive enzymes so that you can digest and absorb the food properly. These enzymes include amylases, proteases, lipases, elastases, and ribonucleases, all enzymes that are responsible for the digestion of carbohydrates, protein and fat, elastin, nucleotides, and more. The remainder of your pancreas, about 1%, contains your endocrine pancreas, and this secretes peptide hormones into your blood to regulate a whole host of metabolic processes in other tissues. And this is significant for people living with all forms of diabetes, but specifically for people who are living with autoimmune forms of diabetes. The islet cells within your pancreas are what make up this endocrine function. And islet cells contain multiple cell types, including alpha cells, beta cells, and delta cells. The beta cells are responsible for the manufacturing and secretion of insulin, and they are the only cell type in your entire body that can manufacture and secrete insulin, which makes them critically important for total body metabolic function. So now we're going to talk about the difference between type 1 and LADA. There are physiological differences between these types of autoimmune diabetes, which make it really important to understand in terms of diagnostics. Type 1 and LADA are both autoimmune conditions. There are subtle physiologic differences that are responsible for important treatment considerations. So first, we're going to look at type 1 diabetes. And in summary, type 1 diabetes is an autoimmune condition. Typically, there are multiple antibodies to either the beta cells or insulin. And there's a 6 to 12 month honeymoon period where the symptoms of type 1 diabetes start to occur. As a result of this rapid degradation of the beta cells or insulin, there's a rapid increase in exogenous insulin requirements. And type 1 diabetes typically affects those that are under 30 years old. When we compare this to LADA diabetes, this is also an autoimmune condition, except that there's only one antibody to either the beta cells or insulin. There's a much longer honeymoon period or period where symptoms start to appear. And so therefore, there's a much more gradual increase in exogenous insulin requirements, and it affects those that are over 30 years of age. So when you've diagnosed type 1 diabetes in the past, you can easily recognize the symptoms and the signs of this rapid loss of insulin production. It causes symptoms that become very clear that there's a serious problem in the body. With LADA, the gradual decline of insulin production is less clear. And because of the age of onset, it often seems more likely that your patient would be living with type 2 diabetes as opposed to an autoimmune form of diabetes. LADA actually behaves more similarly to type 2 diabetes in its initial onset. People living with LADA are often misdiagnosed with type 2 diabetes. LADA shares genetic features with both type 1 and type 2 diabetes. And phenotypically, LADA patients are often misdiagnosed as having type 2. They often have worse A1C levels than type 2 diabetes patients. And as we're learning, LADA is actually one of the most prevalent forms of adult onset autoimmune diabetes and probably the most prevalent form of autoimmune diabetes in general. The prevalence and incidence of type 1 and LADA is difficult to discern. The data around these numbers is a little bit confusing and isn't as clear as we would like. But LADA is the most prevalent form of adult onset autoimmune diabetes. And it occurs in about 10 to 12% of all patients that are diagnosed with diabetes who are over 35 years old. LADA also occurs in 25% of all patients diagnosed with diabetes who are less than 35 years old. So using that 35-year-old cutoff, if you look at your patients diagnosed with diabetes, a good portion of them are likely living with LADA. And this number is found to be increasing over time. We compare that to the worldwide incidence of type 1 diabetes. There's about 15 out of every 1,000 people in the world living with type 1 diabetes. The prevalence is about 9.5%, and that also is increasing. So we don't have an apples to apples comparison of incidence and prevalence, but the takeaway is that both of these forms of diabetes are increasing in people all around the world. So LADA stands for latent autoimmune diabetes in adults. And again, it's marked by the presentation of a singular antibody, the slow and gradual degradation of insulin production, and eventual progression to full insulin dependence. So you can think of it as slow progressing adult onset type 1 diabetes. Now, the clinical characteristics of LADA are very interesting because your patients may present differently with LADA compared with other forms of diabetes. We talked about the progression of insulin degradation being much slower in LADA compared with type 1 diabetes. So your typical symptoms of type 1 diabetes will not apply to people living with LADA. It's much more subtle and can mimic type 2 or even prediabetes in the initial presentation. People living with LADA often don't respond well to oral diabetes medications. And because LADA is autoimmune by nature, oral medications do not often improve hyperglycemia. You also might see your patients presenting with either normal weight, or they may be underweight or just slightly overweight. But compared to patients living with type 2 diabetes, these patients are going to look a little bit more on the normal weight curve. Also, A1C values may only be slightly elevated. And again, with this gradual loss of insulin function or insulin production, there can be just a slight elevation in A1C and a slight elevation in fasting blood glucose values. One of the other characteristics is that you'll see a rapid high glucose elevation within 1 hour of eating. And we're going to look at some CGM patterns in just a minute. There are recommended diagnostic tests that you can use to monitor and learn about your patient's diagnosis. So if you have patients living with any form of diabetes, using a fasting C-peptide test and diabetes antibody panel will help you discern what form of diabetes they're actually living with. C-peptide results may be low or moderately low for people living with LADA. And monitoring serial peptide tests can be very useful in monitoring the decline of insulin production over the course of time. On this slide, you'll see a few pictures of actual glucose patterns of people living with LADA. And some of the key characteristics of this pattern is that you can see this very sharp increase after a meal. And it's followed typically by a very rapid decline. So the first picture on the left, you'll see this very rapid elevation over 200, followed by a very quick decline back to baseline after the meal. And this is really interesting because you're getting into a very high time above range or out of range. And we're going to talk a little bit more about that in a few minutes. But this is a significant blood glucose pattern that is different than other forms of diabetes. So if you have patients that are living with diabetes that are using CGM technology and you're able to look at some of their patterns, you can see this very repeatable pattern of blood glucose for people that are living with LADA. Sometimes the post-meal drop or decline can actually go down into hypoglycemia territory. And that can be very alarming and concerning for your patient and for you as a provider. So this is a really great example of a typical glucose pattern for somebody living with LADA. What you'll see here is a very clear example of somebody with a slightly elevated fasting blood glucose value, just over 100. And then they have a very rapid spike up to or over 200 after their meals. And then they experience some post-meal low values and hypoglycemia. And what you'll see here is the EKG appearance on their blood glucose monitor, or the CGM pattern. These are repeatable CGM patterns in people living with LADA. If your patient is checking their pre-meal and post-meal blood glucose value, they may actually see really stable values. So for somebody who doesn't have CGM, you may see that their pre-meal value is stable, and then 2 hours post-meal, it's also stable. So if you look at this first spike after 6 a.m., you'll see that if this patient were only to monitor that pre-meal value followed by the 2-hour post-meal value, they would probably be looking at very stable blood glucose trending. So you could miss that whole time above range or out of range that happens right after a meal. And these elevations that are happening after meals and that whole area under the curve there, those elevations are what will lead to slightly elevated or moderately high A1C values over the course of time. And so these patterns are very repeatable and really interesting to follow. So here's an example of a case study of one of our clients. And the question is, what type of diabetes is this person actually living with? So this is a person who has a history of gestational diabetes with 3 pregnancies, who was treated with insulin during pregnancy. Post-pregnancy, she was diagnosed with type 2 diabetes and treated with oral glucose-reducing medications for over 10 years. Her A1C during this time was ranging from 6.2 to 6.7. She did adopt a whole food plant-based dietary strategy in 2012 and achieved an A1C of 5.8. When she had her C-peptide tested in 2020, it came out to be 0.26, and her weight was low for her height. She was 5 feet 2 inches and weighed 100 pounds, so she was underweight. At that point, she started insulin therapy and is currently using 8 units of basal insulin and 8 to 10 units of bolus insulin per day. And her current carbohydrate intake is 300 to 350 grams per day, and her A1C remains stable at 5.8 after 2 years on insulin therapy while eating 300 to 350 grams of carbohydrate per day. And this situation is very common for a lot of people who are living with a form of diabetes, of autoimmune diabetes like LADA. It's very gradual, it's slow onset. You don't have a really high A1C that would indicate a very fast onset of autoimmune diabetes. So this person is living with LADA and was able to learn more about her diabetes diagnosis so that she could get the treatment that she needed and started the insulin therapy, which actually has helped her significantly. So now we're going to talk a little bit more about understanding the C-peptide test, because understanding C-peptide physiology and its importance in autoimmune diabetes is really important for your practice and for your patients so that they can get the best diagnosis and ultimately the right treatment to match their form of diabetes. So the first blood test that we've already talked about is the C-peptide test. And it's an extremely important test for those living with any form of autoimmune diabetes. It's a test that asks your pancreas, hey pancreas, how much insulin are you capable of making at this moment in time? It's actually the single most important test to know the answer to because it helps you determine whether your patient has a low, medium, or high insulin requirement, or possibly no insulin requirement at this time. What you see on the screen is a molecule of insulin that's made up of 2 peptide chains or 2 separate pieces. The first piece is actually 2 separate pieces that are shown in red, and that's the insulin. The A chain and B chain are held together by 2 disulfide bridges. That's these blue lines in between the 2 chains of insulin. The second piece in yellow is known as the C-peptide chain. And this is a protein that binds these 2 pieces of insulin together. This gets cut off the second that insulin is secreted into the blood. It actually just is secreted and separates from the insulin molecule. At the moment the C-peptide chain is cut, it does reveal the two pieces of insulin, and insulin goes on to stimulate glucose uptake in many tissues throughout the body. The C-peptide chain has no known functional use, and it's basically circulated in the blood until it's degraded by the liver. So why is this important? And it's really a fascinating part of physiology because the C-peptide chain has a longer half-life than insulin. So it takes a longer time to degrade in the body. And the half-life of insulin is very fast. It's about 3 to 5 minutes, where the half-life of C-peptide is much longer at around 20 to 30 minutes or 5 times as long as insulin. So C-peptide remains in the blood for 5 times as long as insulin. Since C-peptide and insulin are manufactured and secreted in a 1-to-1 molar ratio, every molecule of insulin yields 1 molecule of C-peptide. So they're both in the blood in equal amounts, and because C-peptide is inert, measuring the amount of C-peptide in your blood is less technically demanding and allows you to indirectly measure how much insulin was secreted at that moment. So when you think of C-peptide, think of it as an indirect way of accurately measuring endogenous insulin production. So now we're going to shift into understanding diabetes antibodies. This is an overview of the antibodies panel to distinguish between autoimmune and non-autoimmune diabetes. The second blood test that's important to be aware of when you're understanding autoimmune diabetes is the diabetes antibody panel. And there's 5 diabetes antibodies that are known at this time. The first one is the GAD antibody, and that one is the most common. And the other 4 antibodies are often present in people living with either type 1 or LADA, and they're important to measure because these antibodies affect different parts of the cell. In addition to the GAD, there's the IA2 or IA2A, which is the islet antigen 2 antibody. Then there's antibody number 3, which is a zinc transporter. Antibody number 4, which is the ICA or islet cell antibody. And antibody 5 is the IAA or autoantibody against insulin. So this last one is actually an antibody that attacks insulin that's inside the body. 80% of patients with autoimmunity will test positive for GAD. So as a baseline screening, this is a good place to start, but the rest of the antibody panel is equally important because just because you're negative for GAD doesn't mean that you wouldn't be positive for one of these other antibodies. To definitively diagnose autoimmune diabetes, using a C-peptide test and diabetes antibody panel are important to get the full picture of accurate diagnosis. And because LADA is autoimmune by nature, oral medications do not improve hyperglycemia, and understanding what form of diabetes your patient's living with is really important for getting the proper treatment. This slide shows us a chart of how to interpret the C-peptide and diabetes antibody panel together. And this is a really great way to categorize the levels of C-peptide in the bloodstream along with the presence of antibodies in your blood. So as your patient's results come in, as you see the change of C-peptide from high to low, so from right to left in the columns, insulin does become necessary or likely depending on the level of antibodies. So for example, on the table here, the columns represent the C-peptide level and the rows represent the results of the same patient's antibody panel. So if you take the top row for a patient who tested negative for all the antibodies, which indicates no autoimmunity. And this is an indication that your patient likely is living with type 2 diabetes. And as you move from left to right, you'll see that their need for exogenous insulin goes down. The higher their C-peptide, the more insulin they produce, and the less need for exogenous insulin. In the second row, a patient tested positive for one antibody, suggesting that they have a form of autoimmune diabetes. If the patient is over the age of 30 and tests positive for only one antibody, there's a high likelihood that they are living with LADA, even though this is not definitive. And as you move from left to right, you'll see that the need for exogenous insulin changes. The left 2 boxes indicate a more immediate need for exogenous insulin, and the box on the right indicates a less immediate need for exogenous insulin. In the third row, a patient tested positive for more than one antibody, suggesting that they are likely living with type 1 diabetes. If you combine that with their fasting C-peptide result, a low and medium C-peptide production suggests an immediate need for exogenous insulin, and the box on the right suggests a less immediate need for exogenous insulin. This table is not definitive. However, it's meant to be used as a tool to combine the antibody panel and C-peptide together to determine the best course of action for your patient. Now, when you're ordering these blood tests for your patient, it's important to consider that C-peptide can be measured in both the fasting state or in the postprandial state, so post-meal state. Measuring a C-peptide test in the fasting state will tell you how much insulin is being secreted under baseline or basal conditions. Measuring C-peptide in the postprandial state tells you how much insulin was secreted for a given meal. The fasting C-peptide test is generally considered a more useful test for measuring the insulin secretory capacity of an individual because it's independent of the amount or type of food that a patient ate in the previous few hours. So testing the C-peptide in a fasting state is considered a more reliable test. In addition, antibody tests are clear regardless of fasted state or not. So you could test the antibody panel fasting or non-fasting. So we're going to move into talking a little bit about dietary management for type 1 diabetes and LADA. And first, we're going to review just a little bit about the traditional management strategies. These are some statements that came directly from the ADA consensus statement from 2021 about the management of type 1 diabetes. So nutrition, in particular carbohydrate intake, has a major effect on blood glucose levels. Carbohydrate counting is the most common meal planning approach in type 1 diabetes. And while low carbohydrate and very low carbohydrate eating patterns have become increasingly popular and reduce A1C levels in the short term, it's important to incorporate these in conjunction with healthy eating guidelines. And it's important to point out that nutrition and dietary patterns are very personal for people. There's a lot of information out there about different types of dietary strategies that work for people with all forms of diabetes. Carbohydrate counting and including conversations about carbohydrate counting is important in the management of autoimmune forms of diabetes. And we're going to be going further into detail about the current dietary guidelines in Module 4. So there'll be more information about this in the future as well. But first, we're going to talk about a summary of nutrients in food. So this is basic nutrition in food. All food that you eat consists of multiple nutrients in some proportion. So you have macronutrients, which are the carbohydrates, fat, and protein that make up the food that you're eating. We have micronutrients, which are things like vitamins, minerals, antioxidants, water, and phytochemicals. And then you have fiber, which is another significant nutrient that is contained in food. So because all foods have some proportion of all of these nutrients, it's helpful to understand where you're going to maximize certain nutrients and minimize other nutrients. So for example, in plant-based whole foods tend to have a much higher proportion of carbohydrate and a lower proportion of fat and protein. They're also high in fiber and all micronutrients, vitamins, minerals, phytochemicals. So you'll get much higher proportion of nutrients in general from plant-based whole foods. In the category of processed and refined foods, these foods tend to be very low in micronutrients and fiber, and they tend to be higher in fat. And then non-plant-based foods would be things like meat, dairy, cheese, and eggs. And these tend to be very low in carbohydrate, higher in fat and protein, but also tend to be lower in micronutrients and fiber. So this is a chart that helps to define dietary strategies. And on the left, you'll see a description of different types of diets. And we're going to talk a little bit more about the carbohydrate counts as part of the approach for autoimmune forms of diabetes. So oftentimes people living with autoimmune forms of diabetes are told to modify their carbohydrate intake to some degree. And it's interesting to learn what this actually means, because if your patient doesn't understand how many grams of carbohydrate or what their strategy is supposed to be, it can be very confusing for them to understand what to eat or how to eat or what approach to take. So when you look here at the very low carbohydrate approach, an example of this would be a ketogenic diet. The total amount of carbohydrate per day is 20 to 50 grams. And this equates to, out of your total calories per day or total energy intake, about 10% or less. So this is a very low carbohydrate dietary approach. The next category is low carbohydrate, which typically equals less than 130 grams of carbohydrate per day and would equate to less than 26% of your total calories from carbohydrate. In a moderate carbohydrate approach, you're eating somewhere between 130 to 230 grams per day, and that would equate about 26 to 45% of your total energy or total calories. And the high carbohydrate category is anything more than 230 grams per day, and that would incorporate greater than 45% of your total energy intake. And because carbohydrates are often discussed in diabetes health, it's helpful to understand the percentage of total energy intake in each of these dietary strategies. As the total carbohydrate concentration changes, the proportion of fat and protein also change. So a higher carbohydrate diet will equate to lower fat and protein, and vice versa. The lower carbohydrate tends to equal higher fat and protein. Now, this is the ADA plate method, which is directly from the ADA public website, public domain. And this is a very common strategy used in many healthcare settings to establish a strategy for constructing a meal. And this advice is often given to people living with all forms of diabetes, but specifically with autoimmune diabetes. And the things that we like about this is that they have labeled foods in terms of carbohydrate foods as the picture here shows whole foods, plant-based foods. And that's a really great addition, right? Keeping people mindful about eating whole foods for a healthy dietary strategy. Also, half of the plate is constructed of non-starchy vegetables. And these are foods that are rich in vitamins and minerals, all sorts of micronutrients, as well as fiber. So these are the things that we really like about this strategy. What is a little bit confusing here is the fact that they're using the term protein foods and also the general category of carbohydrate foods, because these foods also contain proportion of fat. The protein foods that are listed here, number 2, could also be foods that are much higher in fat. And we like that it only accounts for a quarter of the plate, but it also could end up increasing the total dietary fat. And as you're going to see in a little bit, we're going to talk about the significance of dietary fat for people living with autoimmune diabetes. So this is something that is shared with patients living with diabetes and could lead to some confusion. You know, the word carbohydrate can be confusing for people. The protein category could be confusing and also could lead to a diet that is higher in fat than one might want to consume. So now we're going to move into the effect of low carbohydrate diets in managing autoimmune diabetes and understanding why the low carbohydrate approach may not be the most ideal strategy in the long term. So all across the internet and as well as in traditional allopathic approach to diabetes, carbohydrate metabolism is thought of as being only influenced by a single variable, carbohydrates. So the story that's told is that if you eat anything containing carbs or carbohydrates, including from whole foods like fruits or potatoes, or if you eat foods containing refined carbohydrates like white sugar, white rice, white flour, or things like cookies or crackers, pastas, breads, all of those things are considered carbohydrates. And regardless of the type of carbohydrate that you eat, the carbohydrates metabolize to sugar. And on the picture in front of you, you'll see that white table sugar is used here on purpose because when people talk about blood sugar, it makes this picture in your mind that all carbohydrate equals sugar and will create the equivalent of white table sugar in their blood. And that's not exactly accurate. And the next step is that the blood sugar elevation spikes insulin or insulin needs, which leads to an increase in the need for either endogenous or exogenous insulin. So here's the problem with this model. It doesn't take into account the effect of any other micro or macronutrient on glucose metabolism, especially fat and protein, both of which play an integral role in influencing insulin requirements. So the A1C value is a critical value to measure in your patient's overall health, regardless of the form of diabetes they're living with, but specifically for people with autoimmune diabetes, because it measures your patient's average blood glucose control over a 3 to 4 month period. Hemoglobin in red blood cells is an oxygen trap whose primary function is to bind oxygen and circulate it to tissues. It turns out that hemoglobin can also bind to glucose easily, which then forms a molecule known as glycated hemoglobin, or A1C. The higher your patient's A1C, the more glucose is bound to hemoglobin, and the higher their average blood glucose has been over the course of 3 to 4 months, or the lifespan of a red blood cell. The lower your patient's A1C, the less glucose is bound to hemoglobin, and the lower their average blood glucose has been over the course of the past 3 to 4 months. So when it comes to A1C, a lower number is better for short and long-term outcomes. The NIH funded the landmark Diabetes Control and Complications Trial, the DCCT, from 1983 to 1993, so over the course of 10 years, and involved more than 1,400 people with type 1 diabetes to determine whether intensive diabetes treatment, including 4 or more blood glucose checks per day and 3 or more insulin injections per day, could slow the development of eye, kidney, and nerve damage. And that group was in comparison with the conventional treatment at that time, which was 1 to 2 insulin injections per day with at least 1 blood glucose or urine glucose check per day. The DCCT showed that people who used intensive treatment and kept their blood glucose levels as close to normal as safely possible lowered their risk of many, many, many complications. They had a lowered risk of diabetic eye disease by 76%. They had a lower risk of diabetic kidney disease by 50%, diabetic nerve disease by 60%. And the DCCT participants who had tight control of their blood glucose levels had a 33% lower risk of death 21 years after the DCCT ended. Therefore, achieving a low A1C value is imperative to increase quality of life and reduce long-term complications. So now let's talk in detail about how specific foods can affect blood glucose control beyond carbohydrates. As we covered a few slides ago, carbohydrate energy does influence glucose metabolism, but fat and protein also have a significant impact on glucose metabolism. And this has to be taken into account for both the short-term and long-term diabetes management of people living with autoimmune forms of diabetes. This graph shows 2 separate blood glucose profiles following one single meal. The graph in red clearly demonstrates a large postprandial glycemic excursion, whereas the graph in green demonstrates a small postprandial glycemic excursion. So you can see the same meal at the same time, and then the timing goes up to 360 minutes or 6 hours after the meal. The profile in red demonstrates what happens to people living with type 1 or LADA when there is a mismatch between food and insulin. The red profile typically results from an insulin insufficiency, and the green profile results from injecting the right amount of insulin for the meal. Even though this only follows a single meal, it's a snapshot in time of how a long-term biomarker like the hemoglobin A1C, which measures 3-month average blood glucose control, can increase. Frequent high glycemic excursions in the postprandial state increase the area under the curve, so all the space under the curve from the beginning of the meal to the end of the meal. All of that time can decrease the time in range, which would increase the A1C value over the course of time. In other words, if this pattern repeats itself frequently, high glycemic excursions like this are additive, meaning that you will have an increase in A1C, worsening metabolic health, and a significantly increased risk for complication like kidney disease, like neuropathy, retinopathy, and increased risk of death, as the DCCT uncovered. So all of this time under the curve outside of a normal excursion can lead to elevated A1C and other complications. People who do eat a low carbohydrate diet they may experience flatline blood glucose, and they may experience having a very low A1C. They'll report that their blood glucose has never been lower, and their glucose ranges between 80 to 90 all day long. And these are people following low carbohydrate or very low carbohydrate approaches. And you can see here potentially on a standard diabetes diet, you might see much bigger excursions, much bigger times outside of range. So their time in range is lower compared with the very low carbohydrate diet below. Low carbohydrate diets will reduce A1C. And you can see here potentially on a standard diabetes diet, and their glucose ranges between people who do eat a low carbohydrate diet, they may experience flatline blood glucose, and they may experience having a very low A1C. They'll report that their blood glucose has never been lower, and their glucose ranges between 80 to 90 all day long. And these are people following low carbohydrate or very low carbohydrate approaches. And you can see here potentially on a standard diabetes diet, you might see much bigger excursions, much bigger times outside of range. So their time in range is lower compared with the very low carbohydrate diet below. Low carbohydrate diets will reduce A1C, but they dramatically increase insulin resistance. So we're going to move into talking about insulin resistance and the impact of insulin resistance on people living with autoimmune forms of diabetes. So if you look at this slide, you'll see that the insulin resistance is at the core of all of these conditions surrounding it. So it's a root condition that underlies or influences other disease processes. So it's responsible for influencing and causing things like prediabetes and type 2 diabetes. It can cause blood glucose variability in people living with autoimmune diabetes. Insulin resistance is also responsible for things like hypertension and atherosclerosis, obesity, high cholesterol, fatty liver disease, as well as the comorbidities or conditions associated with diabetes, neuropathy, blindness, kidney failure, retinopathy, and even erectile dysfunction. As you reverse insulin resistance or prevent it, you will see an improvement or prevention of many of these conditions. In the diabetes world, you can categorize the different flavors of diabetes into 3 different categories. You have your autoimmune forms like type 1 and LADA, your lifestyle-related forms, prediabetes and type 2 diabetes, and then women's health or reproductive forms, which are gestational diabetes and polycystic ovarian syndrome. Insulin resistance influences all of these forms and is the bond that connects all forms of diabetes. So here we have a case study of somebody who is living with type 1 diabetes. This person's been living with type 1 diabetes for over 20 years. And upon their diagnosis of diabetes, was told by the healthcare team to eat a low carbohydrate diet. So the first column shows us the data based on the low carbohydrate dietary approach. The total carbohydrates consumed per day were less than 100 grams. Total fat was over 150 grams per day. It's that inverse relationship of carbohydrate to fat. Their basal and bolus insulin was around 50 units total for the whole day. And at that point, A1C level was ranging around a 6.8%. And their time in range was somewhere between 45 to 50%. So 50% of the time, their blood glucose was in range. The other 50% of the time was out of range, high or low. This person decided to adopt a low-fat, plant-based, whole food dietary approach. So this meant that they changed their dietary strategy to incorporate 700 or more grams of carbohydrates per day from whole foods and lowered their dietary fat to less than 30 grams per day. As a result, their total insulin need decreased by half. Basal insulin and bolus insulin both dropped significantly. And this person has been maintaining an A1C in the 5.4 to 5.7% range for the last 20 years. Their time in range also remains 80 to 90%. And this is really significant because, as you can see, this person's achieved time in range without having multiple hypoglycemic experiences. So they're not experiencing hypoglycemia to get this time in range or this A1C, which is the typical thought process of people who achieve a lower A1C when you're living with type 1 diabetes. Also, interestingly, this person has never developed hyperlipidemia. So there's cholesterol levels are normal, total, there's no hypertension, no retinopathy, no peripheral neuropathy. And for people who are living with diabetes for more than 20 years, these are common conditions that develop over the course of time. So this is one example of somebody who had used a high carbohydrate approach to reverse insulin resistance and maintain very healthy biomarkers. So low carbohydrate diets actually cause insulin resistance in the muscle and liver tissues. And we're going to talk now about how they promote insulin resistance in autoimmune diabetes as well. Insulin resistance is caused by the storage of excess fat in tissues that are not designed to store large quantities of fat. And we're going to go into the physiology of insulin resistance a little bit. So insulin resistance is primarily a dysfunction of muscle and liver tissue. Insulin resistance of the liver leads to fatty liver disease, and insulin resistance of the muscle tissue leads to blood glucose variability or diabetes diagnosis. But insulin resistance can also impair the function of the pancreas. And this is really interesting because insulin resistance is a systemic condition and it influences every single tissue of the body, including organ tissues. And when it comes to diabetes, the pancreas is really an important player in this disease process, and especially when it comes to working with people who have LADA, because if they still have some pancreatic functioning, we want to help them preserve that functioning as long as possible. So we're going to review the sequence of events of insulin resistance, how it builds in your body and how it progresses over time. So initially, during the digestive process, lipids break down and are absorbed much more readily and earlier in the digestive process than glucose. And fatty acids become a byproduct of lipid breakdown. So fatty acids do not require insulin as an escort to get into cells. So they are very easily moving their way into the cells in your body, and they occupy cells faster than glucose, which makes no further room for glucose once it approaches the cell. So step one is that lipids enter the blood before glucose will from the digestive process. In this example, let's pretend that your patient ate a cheeseburger, which contains a significant. So step one is that lipids enter the blood before glucose will from the digestive process. In this example, let's pretend that your patient ate a cheeseburger, which contains a significant quantity of saturated fat from red meat and cheese, in addition to refined carbohydrate from the cheeseburger bun. Saturated fat is packaged into triglyceride in food because triglycerides are the storage form of fat. In your small intestine, the triglyceride molecules from the cheeseburger are broken down into fatty acids. The fatty acids are then absorbed through the walls of your small intestine, and the fatty acids are then repackaged as triglycerides into particles called chylomicrons. Chylomicrons originate in your lymphatic system, and they eventually enter your blood. Once in your blood, they're circulated throughout your body so that your adipose tissue and muscle have a first opportunity to uptake triglycerides from your food. When your small intestine detects fat-soluble nutrients in your food, it releases a collection of powerful hormones that communicate with your brain and stomach to control your appetite and slow your gastric emptying rate, or the rate at which food exits your stomach. In effect, your small intestine says, "Hey, stomach, slow down how quickly you process food. This fatty meal is going to take me some time to digest and absorb." A slowed gastric emptying rate results in an upstream traffic jam, and it slows down the passage of partially digested food material out of your stomach and into your small intestine. So if you've ever noticed that a high-fat meal takes longer for your stomach to process than a lower-fat meal, this is exactly why, because the presence of dietary fat slows the digestion of all food material, causing that sort of traffic jam in your stomach. As a result of the simultaneous fat absorption into your lymphatic system and slowed gastric emptying rate, both carbohydrate and protein digestion are slowed down. The net consequence is that fat-rich chylomicrons appear in your blood more readily than glucose and amino acids. It temporarily keeps blood glucose values low in the beginning stages of digesting a fat-rich meal because the carbohydrate hasn't been broken down into glucose, and that is slowing down that uptake of glucose into your bloodstream. So the second step is that fatty acids will enter the liver and muscle tissue. So here we see a picture of the blood vessel to the right, and inside the blood vessel, you have your fatty acids and you have some glucose, and the glucose eventually will make its way to meet the insulin. So as the fatty acids are inside of your bloodstream, making their way into the muscle and liver very quickly, they will take up space inside the cells of your liver and muscle. So now, by the time the glucose is available in the bloodstream, after the carbohydrate has been broken down, glucose makes its way into the bloodstream and finds some insulin and works its way. So here we see a picture of the blood vessel to the right, and inside the blood vessel, you have your fatty acids and you have some glucose, and the glucose eventually will make its way to meet the insulin. So as the fatty acids are inside of your bloodstream, making their way into the muscle and liver very quickly, they will take up space inside the cells of your liver and muscle. So now, by the time the glucose is available in the bloodstream, after the carbohydrate has been broken down, glucose makes its way into the bloodstream and finds some insulin and works its way over to the cell, except that the cell is already full of fatty acids. So the cell in the muscle, the cell in the liver says, I'm closed for business. I have no room left in my inside of me. So we need to get rid of some of this fat before we can uptake any of that glucose that you have. What ends up happening is the glucose is not available into the muscle and liver tissue, and instead is stuck in the bloodstream. The glucose molecules start to build up, and when somebody checks their blood glucose, they'll start to see their blood glucose level elevating. They'll start to see a rise in glucose because the fatty acids have taken up the space inside the muscle and liver tissue. So the pancreas steps in at this point and says, I'll help. I'll just make more insulin to overpower the muscle and the liver. So now you have higher levels of circulating glucose, higher levels of circulating insulin. And as a result, you end up with a patient who's both hyperinsulinemic and hyperglycemic. And eventually, the pancreas can overproduce insulin to a rate where it will allow the glucose to enter into the muscle and liver tissue. But it takes a lot more insulin to do that, and that's where hyperinsulinemia can develop. One of the most common side effects of eating a high-fat diet is that you can develop fatty liver disease. And fatty liver disease occurs when the amount of fat in your liver is more than 5% by weight. And this results in liver enlargement, which can then lead to liver fibrosis and eventually liver cirrhosis. A growing body of research shows that a high-fat diet results in the progressive decline in liver function over time. And here you can see the comparison of an insulin-sensitive liver, which has a small amount of fatty acids inside the cells, but actually has a pretty even number of glucose and has a room for glucose to enter into the liver, compared with the fatty liver or an insulin-resistant liver, where you see much higher concentrations of fatty acids, higher concentrations of cholesterol deposits, and then lower concentrations of glucose. So what ends up happening is that the glucose ends up staying inside the bloodstream, leading to higher blood glucose values because there's no room inside the liver to uptake glucose for storage. When you develop insulin resistance in your liver due to the accumulation of excess dietary fat, your liver can't communicate with insulin very effectively, which ends up resulting in a chronically high rate of glucose export from the liver, a high fasting blood glucose value, and high post-meal blood glucose values. So when you're in a condition eating high-fat foods, contributing to higher fatty acid uptake into the liver, you end up with higher glucose export from the liver. In effect, the accumulation of these excess fatty acids will prevent your liver from accurately controlling how much glucose and fatty acids it releases into your blood. Simply by becoming partially blind to insulin, the liver loses part of its ability to sense how much glucose and fatty acids to export into the blood. So there's some confusion about how much glucose to export as a result of higher glucose levels inside the bloodstream. And as a result, the liver continues to maintain higher levels of fatty acids. The bloodstream maintains higher levels of glucose and insulin, and the export of fuel is interrupted. So why is accelerated glucose export a problem? Accelerated glucose export will lead to increasing fasting blood glucose and post-meal glucose in your patient. It also will lead to increased blood glucose variability, as well as increased fasting and post-meal insulin concentrations. So you'll see patients again who have high blood glucose, elevated insulin levels, so hyperglycemia and hyperinsulinemia. From a cardiovascular standpoint, you will also see increased VLDL production, increased LDL concentrations, higher risk for arterial plaque, hypertension, increased need for statin medications, and increased risk for all-cause mortality. So why is accelerated glucose export a problem? Accelerated glucose export will lead to increasing fasting blood glucose and post-meal glucose in your patient. It also will lead to increased blood glucose variability, as well as increased fasting and post-meal insulin concentrations. So you'll see patients again who have high blood glucose, elevated insulin levels, so hyperglycemia and hyperinsulinemia. From a cardiovascular standpoint, you will also see increased VLDL production, increased LDL concentrations, higher risk for arterial plaque, hypertension, increased need for statin medications, and increased risk for all-cause mortality. And third, you'll see increased risk for arterial plaque from elevated triglyceride levels, increased risk for hypertension, and LDL cholesterol. And this will also lead to an increased risk for all-cause mortality. So in step 3 of insulin resistance, we now see fatty acids entering the adipose tissue. What happens here is that your fatty acids, as they're circulating throughout the bloodstream, not only will they make their way into the cells of your liver and muscle tissue, they also make their way into the adipose tissue. And adipose tissue is happy about that because adipose tissue has the job of accumulating excess fat, and they are actually the only cells in the body that are designed to store larger amounts of fat. And some of that is protective. It allows you to store energy for the future. But over the course of time, this can become a problem if you continually store excess fatty acids. So eventually, in a condition of a high-fat diet or when dietary fat is elevated, adipose tissues actually can become inflamed. We're going to walk through the mechanism of what's known as adipose tissue infiltration. So fatty acids in lipoprotein particles in your blood are transported as triglyceride molecules. And these lipoprotein particles are directed primarily to your adipose tissue so that fatty acids can be passed along for long-term storage. And so you can see here that the fatty acids in the blood will make their way over to the adipose tissue. Now, as more fatty acids are distributed to your adipose tissue, adipocytes or adipose cells grow in size. These cells can become larger over time simply by storing more fatty acids as triglyceride. At a certain point in this evolution, a chronically high-fat diet can result in what is known as hyperplastic adipocytes, which are adipose tissue cells that have grown beyond their original design. Hyperplastic adipocytes are larger than their physiological normal counterparts, and as they grow larger, they can break the collagen network that holds the tissue together. When cells grow too large, they can also rupture and spill their contents into the extracellular fluid. This can also cause the collagen network that holds the tissue together to break. As cells rupture, they spill their intracellular contents into the extracellular space, which then signals the tissue to secrete inflammatory cytokine molecules that act like a police siren. These cytokines recruit macrophages to the tissue, and as these macrophages arrive to the tissue, they begin endocytosing, or eating, the ruptured cellular debris. So the sequence of events is that the cells become larger, the adipose cells become larger. Eventually, they begin to get hardened on the outside, and then they rupture, leading to this cytokine inflammatory response. These macrophages are extremely effective at cleaning up a site of inflammation. Think of macrophages as the biological version of Pac-Man, who clean up the cellular debris by engulfing waste material. There's no job too big for macrophages. If there's too much debris, they can signal for backup by secreting more cytokines. The problem is that these signals don't just recruit more hungry macrophages. They also trigger chronic inflammation, and in the process create a state of adipose tissue insulin resistance, which makes the adipose tissue less responsive to insulin. Finally, let's talk about the way that beta cells can become lipotoxic. This is critically important because it's the mechanism that links fatty acid exposure with beta cell failure. Research clearly describes how beta cells exposed to chronically high concentrations of lipids will experience a reduced ability to secrete insulin, have an increased risk of death, and an inability to replicate. Remember, beta cells in your pancreas have one function: to manufacture and secrete insulin into your blood. They make up less than 1% of your total pancreas by weight, representing a very small population of cells. Your body has no backup mechanism for producing insulin. So when your beta cell function is compromised, it presents a disastrous metabolic problem to tissues all over your body. In the same way that your liver and muscle tissue are highly sensitive to the accumulation of fat, so are beta cells. So let's see how this process unfolds. Chronic exposure to a high lipid concentration promotes free radical formation inside of the beta cells. Free radicals are electronically unstable molecules that are formed in mitochondria as a result of high exposure to lipids. Free radicals are highly dangerous molecules because they can induce widespread damage in the hunt for a single electron. As they search for that single electron, they migrate to places in the cell where there are abundant electrons or abundant negative charge. The first place they migrate is to DNA because DNA is electron rich. Free radicals can bind to DNA in the nucleus and in the mitochondria, damaging both structures. Free radicals also bind directly to proteins in the cellular architecture wherever they exist. Proteins are ubiquitous in the cell and are found in organelle membranes, in the cellular membrane, in the endoplasmic reticulum, and many other locations. When free radicals bind to proteins, they cause oxidative stress, which can accelerate the journey to cellular dysfunction really quickly. Free radicals also bind directly to lipids in the cellular architecture, in the cell membrane, and in organelle membranes, causing what's known as lipid peroxidation. Similar to protein oxidation, lipid peroxidation accelerates the path to cellular dysfunction. So here we see a normal islet cell, which is capable of responding to increased glucose in the blood very quickly and efficiently. It responds by secreting physiologically normal amounts of insulin, shown here. Step 2, when you have an increasing demand for insulin, it forces beta cells to manufacture insulin in overdrive, creating internal cellular stress. Islet cells become hyperplastic and hyperinsulinemic, meaning that they become larger than normal and secrete less insulin. This process is highly variable between individuals. In some people, it can take many years to develop, while in others, the process can occur within months. And unfortunately, at the end of this phase, the beta cells end up in a state of apoptosis or beta cell suicide. The cells actually self-destruct because they no longer can produce insulin at the same level that they've been asked to produce over the course of time. So the final stage is your beta cells becoming lipotoxic. Now, in the case of autoimmune diabetes, this stage of beta cell destruction can speed up the rate at which exogenous insulin is required. But overall, this is the sequence of events for total body insulin resistance. Excellent blood glucose control does not prevent you from increased tissue inflammation and chronic disease risk. As we've shown, the exposure to high levels of dietary fat are what contribute to the development of insulin resistance and the series of cell dysfunction. So as a result, if somebody is eating a diet that is low in carbohydrate to achieve stable or low blood glucose values, they're still creating a situation in the background of insulin resistance. And that is the problem in the long term for all of our patients. So the accumulation of excess fat in muscle and liver traps glucose in the blood, which causes both hyperglycemia and hyperinsulinemia over time. This is incredibly important for all people, but especially for people living with autoimmune diabetes. As someone living with autoimmune diabetes worsens their insulin resistance, they suffer the consequences of their insulin resistance. They will have increased overall blood glucose levels, increased blood glucose variability, elevated cholesterol levels, inflammation in their cells, and all of the series of events that we saw in the previous slides. The findings of this study actually highlight the significance of dietary fat in considering insulin dosing. And the conclusion is that dietary fat does increase glucose levels and insulin requirements, and it highlights the limitations of the current carbohydrate-based approach to our bolus dosing calculation. There is more research needed in this world of type 1 diabetes and blood glucose management, but this is a really great summary. Now, the significance of somebody living with autoimmune diabetes who develop insulin resistance is that they often eat themselves into double diabetes. So if their dietary strategy is that of a low carbohydrate diet, therefore have increased volume of dietary fat, they can very easily develop insulin resistance and then develop this condition called double diabetes. Double diabetes is the combination of autoimmune diabetes, which is type 1 diabetes or LADA, where there's low insulin or no insulin production, plus insulin resistance of whole body ectopic lipid accumulation, which leads to double diabetes, which means that you have somebody living with autoimmune diabetes and insulin resistance, which could be simplified as somebody living with both type 1 and having symptoms of type 2 diabetes. We're going to talk about this in a case study of one of our clients. He is a person who is living with type 1 diabetes for 57 years. And this person had developed a whole host of complications over the years. He was instructed to eat a low carbohydrate diet, which led him to a very high fat diet over the course of time. And again, living with diabetes for 57 years, he developed hypertension and hyperlipidemia. So he had high blood pressure, high cholesterol. He developed peripheral neuropathy and had very high levels of pain in his feet and hands. He also developed rheumatoid arthritis and depression. This was very taxing on his mental health. When he was first working with us, he weighed 276 pounds and was overweight. He was very challenged to move his body. He was having a hard time exercising. He had a lot of pain from both his neuropathy pain and the rheumatoid arthritis. And he was using upwards of 75 to 100 units of insulin per day. And his A1C would be in the 6.5 range. And at that point, he was eating about 80 grams of carbohydrate. Within a few months of adopting a low-fat, whole-food, plant-based diet, he changed his nutrient intake and he basically flip-flopped to a high carbohydrate approach, eating 250 grams per day. He had lost a significant amount of weight in 3 months' time and had reduced his total insulin down to under 50 units per day. So he went from almost 100 units per day to down to less than 50 units per day and achieved an A1C of 5.6, which was incredible. He also was deprescribed multiple medications for many, many, many different conditions that he had been living with as a result of insulin resistance. The insulin resistance was causing him high cholesterol, high blood pressure. So he was on blood pressure medications. He was also on 2 medications for rheumatoid arthritis, which were also deprescribed to him. We are really happy to share that after 5 years of eating a high carbohydrate or low fat plant-based whole food diet, he was able to maintain a stable weight, and he's now achieved under 200 pounds. So he's no longer obese, no longer living with obesity. He eats upwards of 350 or more carbohydrates per day, grams of carbohydrates per day. He's using equal amounts of basal and bolus insulin, which are appropriate for his weight. And his A1C ranges anywhere between 4.9 and 5.3%. And the beauty of this is that at 62 years old, he is free of cardiovascular disease, free of hypertension. He is active every day. Feels amazing. He reports that he just feels great. His energy levels are so high, and he's had no relapse of his RA symptoms, which is really remarkable because it allows him to live the lifestyle that he wants to live, which is active and, taking really great care of himself. So the only 2 prescriptions that he has at this point are for his basal and bolus insulin to manage his blood glucose for his autoimmune diabetes. And this is somebody who, when he first came to work with us, was confused because his doctor was ready to prescribe him medications that are typically prescribed for type 2 diabetes for reducing blood glucose, decided to look into lifestyle medicine options. The traditional suggested dietary strategy for autoimmune diabetes is to eat a low carbohydrate approach, and therefore one that ends up becoming high in dietary fat. There are some significant short-term improvements in the strategy. When people first adopt a low carbohydrate diet, there are some significant short-term improvements in the strategy. When people first adopt a low carbohydrate diet, they will first notice that they find better blood glucose control. They will see an improved A1C and even weight loss. They can even achieve reduction of cholesterol levels and blood pressure. And these are short-term improvements. Unfortunately, as the dietary fat continues to be elevated, they also develop insulin resistance in all the tissues in their cells. And this is what leads to the long-term side effects of developing conditions like hypertension, high cholesterol levels, and puts people at risk for long-term comorbidities of living with diabetes. There is a large body of compelling research that demonstrates that eating a low carbohydrate diet not only increases your risk for high blood glucose, insulin resistance, weight gain, increased fasting glucose, and fasting insulin concentrations, but it also causes inflammation and promotes heart disease and hypertension over the course of time. So again, you may see some short-term improvements, but you're sacrificing the long-term side effects of long-term health. And as we've talked about, an insulin-sensitive liver and muscle operate in the carbohydrate economy, in which both tissues utilize glucose efficiently in a low-fat environment. So your most insulin-sensitive tissues are going to be low in fatty acid deposits and high in glucose reserves. Insulin-resistant liver and muscle operate in the opposite, which is the fat economy, in which both tissues aren't able to utilize glucose efficiently because they're exposed to a high fat environment. So patients who are insulin sensitive can easily lower their A1C values to a range of 5 to 6%, which is ideal because as the DCCT showed us, the results of long-term complications are dramatically reduced. So we really do want to optimize our patients' A1C values and help them achieve that A1C of 5 to 6%. But we want to help them do that while eating carbohydrate-rich foods that contain high nutrient density. What's interesting is that patients who will eat a low carbohydrate diet or a very low carbohydrate diet can also suppress their A1C value between 4 to 6%. And that's something that will occur in the short term. And that is a great outcome. However, it's very, very difficult in that situation to then eat whole foods, especially plant-based whole foods that are high in nutrient density. So the take-home message is that a low carbohydrate diet or very low carbohydrate diet can suppress your patient's A1C value, which is why it makes many people believe that it's the right answer for long-term health. However, in an insulin-sensitive state, we consistently see non-diabetic A1C values, as well as improvements in cardiovascular disease, hypertension, and many other diabetes comorbidities. And that is something that will help your patients achieve their ultimate and ideal health in the long term. So insulin sensitivity is an important strategy for your patients that are living with autoimmune diabetes, as well as any form of diabetes. But in particular, for autoimmune diabetes, helping them achieve insulin sensitivity will allow them to get the best control of their blood glucose overall. It will help them achieve their best short-term and long-term health goals. And by reducing insulin resistance, they're going to have better overall blood glucose control, less variability, better time in range, and they're going to feel better and be able to utilize their body and move their body the way that they want to. And so achieving insulin sensitivity in their tissues is a really important goal for patients living with any form of autoimmune diabetes. We are going to talk more about that in module 4 and how to help your patients achieve the best insulin sensitivity. So we have covered quite a bit today. So let's review what we've learned in this lesson. First, we learned that there are specific differences between the presentation of type 1 and LADA based on the number of antibodies, the age of diagnosis, and the patient's C-peptide value. We then talked about how low carbohydrate diets can cause insulin resistance in both type 1 and LADA, and how this can then also lead to a condition called double diabetes, which is autoimmune diabetes plus insulin resistance. Then we talked about the specifics of C-peptide value and why that's one of the most important tests to know the answer to for all of your patients living with diabetes so that you're sure of the treatment process and what treatment plan you're going to make with them. And finally, we discussed the biological mechanism of insulin resistance in the liver, muscle, and adipose tissue. Thank you for being here. We really hope you can apply this information to all of your patients living